There's a guy called William Osler.
William Osler.
In the 1800s.
Of Osler's notes.
He actually did say that if you listen to the patient, they'll literally tell what their diagnosis is.
Yeah.
And I've not found this true than getting to listen to patients who have endometriosis. So yes, you listen, and you really pick it up. So we really pick it up from
history.
From history. And what will follow then would be now the imaging. So imaging is telling you how much disease there is.
Where is it?
It does not.
Does it say where? Can you imagine?
Yeah, absolutely.
Okay.
Yeah. If it's done by an expert, so you can really tell where exactly the location is, and that really helps you in terms of executing treatment.
Okay. So what imaging do you do? Ultrasound?
Ultrasound scan.
Okay.
Yeah.
And then what's now? Okay, now you have the diagnosis. What determines the prognosis? Because I'm asking this because I'm going back to Njagi, and because her story made headlines all over. And she had access to treatment. She had fundraisers. She had to go outside the country. She had several surgeries, but still, she couldn't beat the disease.
Yeah.
So, like, from your experience, what is the prognosis? What determines outcomes?
I really say so. First of all, may her soul rest in peace.
She rest well.
She was an amazing woman, and she really contributed a lot to endometriosis. And I had a great opportunity to have a conversation with her and really promoting the work that she was doing. What we know is that endometriosis, can advance in terms of severity.
It can.
Yeah, over time. So the earlier you get it, the better. And so I would really see we giving that reference, it was delayed in diagnosis. Really delayed in diagnosis. So by the time she was getting drained from the chest, that means she had already had endometriosis of the lungs, or what we call the pulmonary endometriosis. And that's really advanced. So the surgery was quite extensive. The surgery literally means that you have to really cut out the disease. So the prognosis, the worse the disease, any disease, the worse it is, the poor the prognosis. And I would say that is...
So an early diagnosis makes a big difference.
By all means. By all means.
Okay. And now this question, a bit controversial from what I've seen when the discussions around it. Because the way you're describing it is how we literally talk about cancer. We say cancer, you come early, it's not too advanced to sort it out. Yeah. When you come late and it's already gone, there's little we can do.
Correct.
So why hasn't this particular diagnosis been classified as a cancer? What makes it different?
We know endometriosis honestly behaves like cancer.
Yeah, it does, because it spreads.
Really does behave like cancer. But the progression and the level of infiltration and if it's not really, malignant. And there are people who have actually been saying, why does endometriosis not classified as a malignant? But
I've seen
it
that.
Doesn't have characteristic of malignancy, though it behaves like one. It has infiltration and so. But the progression is really slow.
Oh, okay.
So that's really one, good thing. And we know that for cancers, is the tissue lose their integrity.
The cells are not really.
So that the cell just changed to be something totally different, which is not.
So in endometriosis, the cells
endometriosis is still the same
endometrial
stroma, which resemble the lining of the uterus. So you don't lose that kind of, let me say, identity in a way. But then it starts invading. So that's what we really find. It's much better than malignancy, but it behaves more or less the same. I don't think we are going to get to it being classified because it doesn't meet
because it is not
threshold, because it's really not. But it's correct to say behaves like,
but it is not.
It's not.
That's good clarity.
Yeah.
Only on Daktari A Quick One.
Absolutely.
Okay, so you're saying you've chosen this path. Like, do you still do other things? Do you still deliver babies? Because I think that's the primary role of the. Are you still an obstetrician, or you just became a gynecologist?
Did you really have to ask that?
Yeah. Do you still, or now you're subspecialist? Do you still have those clients who come for NC, follow them up?
Honestly, well, I didn't see this one.
You didn't see that one coming.
No, I don't practice obstetrics
at all.
No, I don't. For a few reasons. Now, I think there's a question you started with. I chose this. I really wouldn't say I really chose endometriosis because I never knew it existed. I think endometriosis chose me.
It just came along.
Or God,
assigned me.
Like,
Yo, Njagi.
Yeah. Who was this? Was being called Moses.
Was it Moses? Or Samuel?
Or
Samuel.
Samuel.
Yeah.
Samuel. So it's like Njagi.
What is endometriosis?
Yeah, what is endometriosis? And what? But anyway, I really felt that in everything that we do, if we have to be good at it, we need to dedicate our full time to it. And the amount that I would dedicate to obstetrics or delivery, if I take that time and dedicate it to endometriosis, there's no question of definitely good.
You make more impact.
So I felt in my early days that there's so many of us who can take care of obstetrics because we are trained that
everybody.
Yeah.
But there's very few people who
can take care of so this is what we call special mention. Sorry, I'm not
special mention.
Mission possible. So I really felt that I needed to free my time for me to give my full attention to laparoscopy and endometriosis. Of course, obstetrics really needs you to be there.
Yeah.
So the 9 months that this patient is pregnant and they have come to you, you really have to be there. And that sometimes, if you have to deliver, is going to tire you. So with me hopping everywhere, conferences,
talks,
being here. Can you imagine if I was here, my phone would be over there?
Yeah.
And I know I have two patients who are in labor, and they call and say, "Hey, your patient is on second stage."
Yeah.
Man, I have to say goodbye. We'll finish this tomorrow.
Yeah.
But I mean, I can switch off my phone. I can sleep. I can just wake up tomorrow and there's this congress that is happening, on the other part of the globe. And it's impressive. I can be invited and present.
So it gives you more freedom.
It gave me freedom to really do this. And I'm quite happy.
And it makes you happy.
And I'm happy.
You seem very happy. Seem very happy, which is good.
I am?
Yeah. We saw you the other day saying you also have a doctor, the doctor's doctor.
Oh, come on now.
and you were so proud.
Daktari.
Like, must be nice. Yeah. Okay.
Yeah.
So, what's if I may ask, as you're concluding on this endometriosis, is there a case that you could say has been maybe very challenging, apart from maybe the Njagi one that made global news. Oh, okay, national news. Is there a case that you faced and you're like, wow, very interesting or very difficult?
Well, yeah, I'd really say
that stands out.
The more challenging, the more the case stands out.
The more the more difficult it is.
The more difficult, the more
type A personality.
Yeah. So you like bring them on, them on. I'd really say to me, the one that really stands out is the patient that we managed with pulmonary endometriosis, and it was really a unique case because you have to get into the chest cavity, and that is not my usual territory.
Yeah.
So you're with.
So in that case, you get the
cardiothoracic. Yeah. So you're getting in a territory that's not yours, and everything completely changes because it's not what you're used to.
Where's the cervix here?
Okay, you're looking for the cervix. You're looking for the ovary, and like you just seeing the lungs just ballooning
and going back.
And what was really funny is like you have to wait. So it balloons. You wait. It
when
collapses.
It collapses is when
and then you do. So you like work, rest, work. And sometimes we ask the anesthetist, please
to increase the rest time.
So just collapse the lung for so much time because we have a bleeding vessel here. We have to take care of it, and they actually really completely deflate that lung, and so you're just there. You're working on time, and then the monitor you're just only listening to the monitor behind. And you can feel the SpO2 saturation just going down and going down and going, and it's coming. You're like, are we there yet? That I think was really fascinating. And I think the other one that I say we just did recently was a ureteric endometriosis. Those are really fascinating. Ureteric endometriosis. This patient had traveled from Burundi. She had traveled. So she left Burundi. She went to South Africa. She came to Rwanda. She came to Kenya. And actually, when she came to Kenya, she was not coming to us.
Oh.
She was going to one of renowned hospital. And then she goes. The husband is a doctor, so he kind of knew stuff. So he comes here, and then she's told that you have dilated ureter and dilated kidney. And all that we need to do is put in a stent, the tube that we put.
DJ stent?
And it really did make sense. You say, no, I'm not really convinced.
That's the husband now.
That's the husband. And then he's talking to a colleague, and you say, you are here? Yeah. Endometriosis. There's a guy called Dr. George.
So the diagnosis had already been made.
The diagnosis was kind of made. And so he reached out to me. This was really interesting. So he reached out to me and said, okay, fine, I'll see her. But you need to be discharged because I don't have rights of admission where she is. In that hospital.
Yeah.
And, she came, and I was a bit anxious because this was a really bad case. Really, really. I mean, the ureter was this dilated. And, getting to the point of obstruction, oh my goodness, was crazy. It's just like, you're riding along the ureter and you don't want to injure it, and it just literally dilated, and getting to where there was obstruction, it was just amazing, man. So of course, when you get there, you have to call the urologist. And it was for the first time cutting the ureter. And then
the thing you usually say, don't cut.
They still say that gynecologists are the worst enemy to the ureter. And they sound like
you're like, yes.
Yeah. The urologist is there like, how do you like me now? I'm intentionally cutting it, just like playing with him. Can I cut here? Can I cut here? So those were really
it was reconnected and it flew?
Left us stents, and then, she went back home. And only 3 words that I always recall after all that. God bless you.
Oh, man.
Like, man, that's the best paycheck.
It is.
I can ever get.
It is, man.
That's $1 billion paycheck.
That is true. That is true. God damn. So she completely recovered. Now let me ask. Now this is out of curiosity, because endometriosis flares up in the cyclical manner. That
Ideally, yes.
Yeah. So when there's obstruction in the ureter, does it relieve when she's not, or in different types of the periods of the cycle? I mean.
No. So what we know is that whatever the ureter really runs along, if you have endometriosis overlying, so of course there's fibrosis. So this is a slow
Also
process
over time.
And most time patients don't get the classical symptom for obstruction, like if you tie, like get during surgeries that we perform, the patient is going to present with pain. So because this is gradual, they don't have these symptoms at all. And that's where we see that patients have what we call silent kidney. So the kidney dies because you had no idea. Because this is it's a chronic injury to the kidney. You really didn't really know about it. So if you have this and it's chronic, there's some tests that we do, and there are a few patients that we have had to remove their kidneys because it was dead.
So ureteric is quite common?
It is very common. Very common. Yeah. So usually we say that the commonest is other than outside the uterus, behind the uterus. If we talk about the organs, the second is after the uterus is the bowel. So bowel, I see that a lot. After bowel will be the ureter, and after the ureter will be the bladder.
Oh, okay. Yeah. Surrounding structures.
Yeah. Really. So it's like what we say: anterior compartment, posterior compartment. Most of the diseases in the posterior compartment.
Okay.
Yeah. So like behind the uterus.
How fulfilling is this? You said God bless you is there.
Yeah. I'd say I only relate this to the last time that last year about one, when I submitted Batian.
You submitted?
Batian.
Oh, Batian is on what? Which mountain?
All right.
Or Batian is the mountain, or it's a summit on a mountain.
Bro,
that's my geography.
Your geography. I need to call your geography teacher. Hey, come on, get your guy here. There's something he missed out.
He was called Mr. Shimeha.
Mr.
Shimeha just taught us about making Zeugens and Batians and how they come along. And today I'm like, why do I know this stuff?
You had it, but you never made it clear.
Batian is
Batian is the highest peak of Mount Kenya. So Mount Kenya has three common peaks. So you have Batian, you have Nelion, and then you have Lenana. So Lenana is the highest point that you can hike. And then Nelion is the second tallest, and then you have Batian.
Oh, so you summited?
So I summited Batian. So summiting Nelion and Batian is usually a technical climb. And is when you do that and you really get at the top, man, the feeling is out of this world, man.
Hypoxia?
Oh, I mean, the feeling that you've conquered.
You feel on top of the world.
Yeah. Of course, you feel really crappy once you go down because of hypoxia and, mountain sickness. But that feeling that it was challenging and I've conquered this mountain, it's a feeling that you cannot explain. And you just sit there at the summit for less than an hour. Because you gotta start.
Go
so
down.
that's really the feeling that I can relate it with. So it's when you get that mountain and you're just like, how do you like me now?
Wow.
It's fulfilling.
The same feeling.
It's the same feeling. So you because it's a monster.
Yeah.
That most people don't get it right. Patients will come, they've had like 3, 4, 5 surgeries. And still. And then you actually go in there and then you hug it. So you feel good that God has given you that grace, but more importantly, you're happy for the patient. That after searching for solution for so long, at least for once, they'll know how it feels to be free of pain. Man, that feeling, you cannot replace it with nothing on planet Earth for me.
Amazing. Now you make me want to become a gynecologist.
Are you thinking about any other specialization?
Oh yeah, I've never really seriously thought about going into gyne, because and this is what I think when it comes to specializations and how we choose specializations. You see, when you were choosing gyne, you didn't know about endometriosis. As you said, endometriosis kind of chose you.
Absolutely,
because you hadn't heard about it, found you along the way.
Right.
Same for us. Most of the gyne where I work is just deliveries, a hysterectomy here and there, myomectomy, and you're like, really? Do I really want to do this? Called 1% my entire life.
Oh, come on. Remember, you're talking to a gynecologist here, bro.
I know, but there are people who like that.
Yeah.
But there are people who, some of us, we want, today I'm here, tomorrow I'm there, today I'm here. So there's that. And then also now you do not have the full range of exposure. Yeah. Because
I think for me, I'd really say it's what makes you happy.
What makes you happy?
Whether it's gynecology, whether it's ENT, whether it's whatever that is, it's what makes you happy. And I usually say, for me, it's whatever you choose to be, you gotta be best at it. Yeah. There's no second option. It's that, and that's what it is. Is it for me? If I gotta do it, and be goddamn so good at it that I can almost question myself. Like, you're having conversation with yourself, dude. Is that you? And I turn on the other side. Who do you think it was?
That argument, the likes of me, who have not yet specialized, talk about is the job market. Because people are like, hey, you want to become a gynecologist? But there are like so many. There's only a few, enough mothers giving birth. There's a gynecologist at every corner. But then you see, there's that lack of exposure that you could actually go into a subspecialty within that. And, as you were saying, create your own niche. It's something that you stand for, just within. It's something some of us have never been exposed to. So.